All right, what's going on, everyone? My name is Ethan, and this is NP Crash Course. And today we are going to be focusing on asthma. We're going to be going over the pathophysiology, signs and symptoms, how to diagnose, treatment, and much more. So if you like this video, make sure to like, comment, and subscribe. And make sure to hit that notification bell so that you will know more of my videos are going to be coming out, okay? So let's go over from the beginning. What is asthma? Well, asthma is a chronic inflammatory airway disease and is characterized by reversible airflow obstruction and bronchial hyperresponsiveness. Now, the inflammation leads to mucosal edema, mucus hypersecretion, and smooth muscle constriction. And it's triggered by allergens, infections, exercise, cold air, or irritants. Now let's go over the signs and symptoms. With signs and symptoms, you're going to be having episodic wheezing, cough, which is especially at night, shortness of breath, chest tightness. You may have prolonged expiration, use of accessory muscles, or nasal flaring. With the nasal flaring, that's going to be more prominent in children, so just remember that. Now the symptoms are variable and it's often worse at night or in the early morning. Now let's go over the risk factors and epidemiology. Now, the family history will have possible asthma, personal history of allergies or eczema that can have the patient be diagnosed with asthma as well. Some other risk factors are obesity, smoking, GERD, occupational exposures, and viral respiratory infections. Now, it's more common in children and it often persists into adulthood. Sometimes people can not have asthma anymore. They can grow out of it. However, there are some individuals who go into their teenage years and even into their adulthood life where they still are diagnosed with asthma and they still have the signs and symptoms. Now let's go over some differential diagnoses. So when you are assessing this patient and you're trying to figure out, okay, what are some possible diagnoses for these patients? Well, some are going to be COPD, GERD, vocal cord dysfunction, congestive heart failure, and maybe a foreign body, or even anxiety. Now then, let's take a look at the diagnostics. So you're going to have a spirometry. There's going to be a decrease in the FEV1 slash FVC ratio, which is going to be less than 0.75 to 0.8 in adults, and equal or greater than 12% improvement in FEV1 post bronchodilator and confirms reversibility. A peak expiratory flow monitoring and the daily variability can be more than 10%, and FeNO, which is exhaled nitric oxide, it will be elevated in eosinophilic asthma. And then other diagnostics is allergy testing, a chest x-ray to rule out other causes if needed. Now with the diagnostic criteria, there should be a history of variable respiratory symptoms such as wheezing, shortness of breath, chest tightness, cough, and a confirmed variable expiratory airflow limitation by spirometry or PEF monitoring. Now you're going to have a classification of severity. So you're going to have intermittent, and that's going to be equal or less than 2 days a week, with the FEV1 being greater than 80%. Mild persistent will be greater than 2 days a week, FEV1 still greater than 80%. Moderate, which will be daily, FEV1 will be 60 to 80%, and severe, which will be continuous, FEV1 less than 60%. Now, let's go over some of the treatments stepwise. So, step one, you're going to have the as-needed ICS formoterol. Examples are going to be budesonide or formoterol. You're also going to have daily ICS such as fluticasone or PRN ICS for Mortorol. Step 3, you will have a low-dose ICS, LABA, an example being fluticasone and salmeterol. Step 4 will be a medium dose ICS LABA, and step 5 you'll add there will be add biologics, an example being omalizumab and dupilumab. Now, let's say the patient has an acute exasperation. So then you will be giving the patient a short-acting beta agonist, such as buterol. You could give the patient an oral corticosteroid, such as prednisone. And if the SpO2 gets lower than 90%, then you will provide oxygen therapy. Now, as for patient education, so you're going to want to inform the patient of the importance of controller versus reliever meds, the use of inhalers with spacers. You're going to recognize signs of worsening control and create an asthma action plan. So you would have a green, yellow, red zones as well. And you would encourage adherence even when asymptomatic. Remember, you gotta have the patient know the difference between the controller and the reliever. So there's a lot of patients who take albuterol and they take it every single day even though they're not wheezing. Or it'll be vice versa, where they might have Alvesco and they will take Alvesco when they're wheezing. And it's like, no, yeah, the patient should have the prescribed rescue inhaler, which is going to be that albuterol. So just make sure to educate your patient properly. Now here are the asthma action plan zones. So green, PEF is greater than 80%, continue medications. Yellow, PEF 50 to 80%, increase reliever, consider oral steroids. And red, which is going to be PEF less than 50%, use reliever and seek emergency care. Now, some common medication side effects. We're going to have albuterol, tremors, tachycardia, inhaled corticosteroids, possible oral thrush, and hoarseness. LABA's possible side effects are headache and nervousness, and oral corticosteroids, possible mood changes and hyperglycemia. Now, for monitoring and follow-up, it's going to be every 2 to 6 weeks after therapy changes, 1 to 6 months if controlled. The patient should have an annual spirometry be performed and monitor for ICS side effects. Now, for patients who have asthma and they belong to certain populations, so for children, you're going to use an age-appropriate devices such as the spacers or the masks, and you're going to inform the patient how to use those techniques. Pregnancy, budesonide is actually preferred, and elderly, you should watch for comorbid COPD and drug side effects. Some side effects to note are possible tremors and palpitations. Now then, let's take a look at the ICD-10. So for ICD-10, they're going to be J45.20, which is intermittent, J45.30, mild persistent, J45.40, which is moderate persistent, and J45.50, which is severe persistent. So when you're going to be billing the patient and giving them the correct diagnoses, you just have to make sure which type of asthma it is: intermittent, mild persistent, moderate persistent, or severe persistent. And now for the EM coding and quality tips. So for the EM coding, you should do 99213 for routine, 99214 for poorly controlled, and use time-based billing on more than 50% on counseling. And some clinical pearls. Ask about nocturnal symptoms and SABA use. Check inhaler technique every visit. And even mild asthma can be fatal. So if a patient does have asthma and they're having a mild attack, it could just go from 0 to 100 just like that. So just remember, even mild asthma can be fatal. And that is it. Thank you so much for watching. Just make sure to like, subscribe, and follow for more FMP board review videos. And comment below with questions or requests. Let me know if there's anything that I need to improve on, and I'll definitely take your advice with seriousness. Thank you for watching and have a good day.